Hello, I'm Jon Salmanton-García from the Institute of Translational Research of the University of Cologne in Germany. And today I would like to share with you some results from the EPICOVIDEHA registry based on respiratory viruses in patients with hematological malignancy. These are my conflicts of interest. And first of all, to give a background to this presentation, it is important to remember that community-acquired respiratory viral infections are a major concern for certain patients, including those with hematological malignancies and especially after an hematopoietic stem cell transplantation. Community-acquired respiratory viruses can undermine, posing significant complications in patients receiving anti-cancer treatment and the associated effectiveness. However, recent advancements, or actually recent advancements in understanding and managing the community-acquired respiratory viruses are reflected in increasing scientific literature and guidelines. This is especially true for COVID-19. And on the other hand, there is a scarcity in large-scale data from cooperative registries on community-acquired respiratory viruses in hematological malignancies, which is something crucial for evidence-based strategies. The EPICOVIDEHA registry, I mentioned before that it's the source where these data will present are coming from, was set in 2021 and collected extensive data on SARS-CoV-2 infections in hematological malignancy patients, and which basically helped a lot clinicians during the COVID-19 pandemic. Insights from the registry have resulted in scientific publications and preventive strategies for hematological malignancy patients. However, additionally, actually, in 2023, EPICOVIDEHA expanded and lost its only focus on SARS-CoV-2, and it became open to any community-acquired respiratory viruses, including influenza, RSV, rhinovirus, parainfluenza, metapneumovirus, and other viruses. The patient source of the data I'm sharing with you now is basically EPICOVIDEHA registry with cases diagnosed with this community-acquired respiratory viral infection between September 1st, 2023 and March 31st, 2024. So basically the autumn-winter season 23-24. The eligible patients were as any patient included in EPICOVIDEHA, active hematological malignancy within the 5 years before the infection diagnosis, adult patients, and laboratory-based or laboratory-confirmed community-acquired respiratory viral infection. The data we collected were basically based on demographics, hematological malignancy management, also on the infection, the presence of symptoms, treatments, including vaccines administered within the prior year, and outcomes. Due to the seasonality and in order to be certain of all these strains, we collected cases only from the boreal countries, basically the northern hemisphere. Most of the cases came from Italy, as we can see, 1/3 actually, and then from Spain or Czechia with 13% respectively, and other relevant countries or with a relevant amount of patients contributed were Hungary, with 18, Netherlands, 55, Germany, Poland, or Turkey. In total, there were patients, or in total, 1,312 patients were collected from all the participants. Half of them, 639, were SARS-CoV-2 patients. Afterwards, 20% were influenza cases, 10% RSV, another 10% rhinovirus, 2% parainfluenza and metapneumovirus, each of them, and 8% other viruses. If we focus on the diagnosis month, we can see something expected. The season started in September 2023, it finished in March 2024, and we have a peak of the cases 1/4, 25% in December. And from that date or up to that date, there is an increasing number of cases, and from there, a decreasing number of cases. If we focus or if we pay more attention to the viruses involved in these infections during the respective months, we can see how in the end of the year, there was a prevalence or higher prevalence of SARS-CoV-2 and rhinovirus, which is common based on the annual epidemiology and seasonality of the viruses. Then in December, we start seeing the increasing of influenza cases. For January, already influenza, sorry, it's the main pathogen, which continues that way for February and March. In February, RSV together with influenza, which both of them are winter pathogens. And then in March, with the start of the spring, we have metapneumovirus appearing as relevant. Interestingly, we can see how in January 2024, there was the highest number of virus combinations or co-infections. If we look to the baseline malignancy and the distribution per virus, we see stable distribution. In all the cases, SARS-CoV-2 is the most prevalent virus, especially in the middle in chronic lymphocytic leukemia, and then mainly influenza and RSV. In certain cases, for example, in the right myelodysplastic syndrome, we have the third most common as rhinovirus, and in chronic myeloid malignancies, we have metapneumovirus as the most common. But otherwise, top three are SARS-CoV-2, influenza, and RSV or rhinovirus. For the distribution of baseline comorbidity and virus, we have also a stable top three. First, chronic cardiopathy, second, chronic pulmonary disease, and third, diabetes mellitus. We can see how the chronic cardiopathy is definitely the most common one, and afterwards, depending on the pathogen, the chronic pulmonary disease or diabetes mellitus, and then other relevant underlying conditions, basically renal impairment, and depending on the case, also obesity. As for the state during the viral infection, we can see the distribution, how it's not exactly the same depending on the virus. We have influenza, RSV, and metapneumovirus as the viral infections with the highest number of hospitalization, either in normal wards or in intensive care units. And if we focus precisely on intensive care units, we can see how more than 10%, between 10 and 15% of the cases with influenza, parainfluenza, or metapneumovirus needed ICU admission. Moving forward to the infection treatment, we can see something probably expected. 70% and 80% of the cases with SARS-CoV-2 and influenza respectively did get a treatment, basically because these viral infections do have a treatment option. In the case of SARS-CoV-2, we have nirmatrelvir, ritonavir, or remdesivir, and also in some other countries, molnupiravir too, and in influenza, oseltamivir. And then we have in the rest of the infections lower numbers of treatment. In RSV, we have around 50% of treatment, mainly associated to administration of ribavirin, and in the rest, basically treatment with corticosteroids, with immunoglobulins, with or without other treatment options, and basically in most of the cases no treatment. 66% were 2/3 of no treatment in RSV, 86% in rhinovirus, 93% in parainfluenza, and 71% in metapneumovirus. For secondary infections, well, mainly bacterial co-infections, especially in RSV, rhinovirus, and parainfluenza. For other viral infections, apart from the present one, the most common secondary viral infections are in rhinovirus, parainfluenza, and metapneumovirus, and secondary viral infections are more frequent in parainfluenza. Anyhow, except for the secondary bacterial infections, which are common in between 15 and 20% in RSV, rhinovirus, and parainfluenza, we would have to speak always to an incidence below 10% of secondary infection, regardless of the pathogen. And day 30 mortality, here we have data. Blue lines indicate patients alive, so we have to focus on the orange ones, which are the absolute mortality, all recent mortality, and the gray ones, which are the virus attributable mortality. Highest mortalities in parainfluenza, 20%, in metapneumovirus, 7%, and in parainfluenza, 9%. And if we focus precisely on the attributable mortality, we can see how in influenza most of the cases are associated, or most of the mortalities are associated to the influenza itself, and in metapneumovirus and in parainfluenza, more or less half of the cases. Moving forward, if we look for the day 30 survival probability, we can see how there are statistically significant differences, having parainfluenza with lower survival probability, a significant lower survival probability as compared to SARS-CoV-2, RSV, and rhinovirus, and influenza with a lower survival probability as compared to rhinovirus. Factors associated with 30-day mortality. Well, overall, we have parainfluenza patients with an increased mortality. Also, patients with smoking history, patients with lymphopenia, also patients with secondary bacterial infection, and as one could imagine, hospital admission and definitely admission in the ICU. If we look for specific viruses, we have done the analysis for the three main ones, SARS-CoV-2, influenza, and RSV, and the reasons associated to mortality in these viruses are respectively for SARS-CoV-2, lymphopenia, active malignancy, secondary fungal infection, and hospitalization with or without ICU admission. In the case of influenza, lymphopenia and secondary bacterial infection, and in the case of RSV, it would be secondary bacterial infection and secondary viral infection. So with this, we can come to the following conclusions. First one is that community-acquired respiratory viral infections pose a significant risk to hematological malignancy patients with elevated mortality linked to different factors, such as active malignancies, secondary bacterial infections, ICU admissions, and lymphopenia. With this study, we have observed seasonal peaks, basically of SARS-CoV-2 dominating until late 2023 and influenza in early 2024, and also high comorbidity prevalence, which necessitates a multidisciplinary care approach. And here we speak about chronic heart diseases, chronic lung diseases, and diabetes mellitus. And last but not least, severe community-acquired respiratory viruses often require ICU care. And basically, this brings us to the reinforcement in the statement of needing for a better antiviral treatments, particularly for parainfluenza and metapneumovirus. In this case, not even better, but just treatments, and also prophylaxis against these viral infections. Thank you very much, and see you next time.